Pull it down. Pull it down.
Hello. Good morning.
Right, good morning to you all. I guess everybody can hear me good.
Yeah, I can hear you.
Thank you very much for making time to join us for this conversation. This very, very important conversation. I'd like us to start off with you. I guess everybody introducing yourself.
Yeah, I can hear you.
Thank you very much for making time to join us for this conversation. This very, very important conversation. I'd like us to start off with you. I guess everybody introducing yourself.
Yeah, I can hear you.
Thank you very much for making time to join us for this conversation. Start off with you. I guess everybody introducing yourself.
Yeah, I can hear you.
Thank you very much for making time to join us for this conversation. Start off with you. I guess everybody introducing yourself. Thank you very much for making time to join us for this conversation. Just a second, I think I need to fix Okay, sorry about that. I think I have resolved the challenge now, and you can all hear me good.
Yeah.
Okay. So I want you to start, let's start off by introducing yourselves. I want Dr. Piakubi to start his introduction.
Okay, thank you very much, Israel. Thank you for having me here. My name is Dr. Piakubi. I'm I'm a medical doctor by profession. I'm a final year PhD student at the Department of Obstetrics and Gynecology at the Chinese University of Hong Kong. Basically, that's it.
All right, so let me have Dr. Emma. So we have two Emmas in this conversation. We have Dr. Emma from London. I want you to introduce yourself too.
Good afternoon. Thank you for having me on. My name is Dr. Emma Amwafo-Mensah. I'm a medical doctor in London, and I've been working in a large teaching hospital during the COVID-19 pandemic.
All right, thank you. Now let's have, let me see if we have the second Dr. Emma on. All right, let's go to you, Nana Tima. Nana Tima.
Hi, Israel. Hello.
Yeah, Nana Tima.
Yes, Israel. Can you hear me?
Yes, I can.
Okay.
So I want you to introduce yourself, please.
Okay, so my name is Nana Tima Boache, and I work with the Ministry of Education. I am the Deputy National Coordinator for the Free Senior High School Secretariat. Yeah.
Okay, thank you. So let me see who else we have on. All right, so let's see who else we have on the line. And I also have, by the way, I have my wife who's going to be my co-anchor also, somewhere in the background. She'll be joining us with comments as we get comments on. Can we have the rest of them? I have Nyamiche. So I have the names on, but I'm not sure who the exact names. So can I have you just introduce yourself, those who haven't introduced themselves yet? And I'd like to see your videos as well.
Yeah, hello. Good morning, Israel.
Okay, so we have Dr. Owu.
Good morning, and good morning to all the participants and your audience. So my name is Chris Owu. I'm a consultant anesthesiologist and intensivist. I'm head of ICU in hospital, and I teach for the university. I coordinate the national COVID-19 severe and critical cases for Ghana.
Okay, all right, so let me just start off by telling you why this conversation has become really important. There are lots of people who actually think that COVID-19 is a scam. Some people call it a scamdemic. But we all know, and the reason why I brought you on here is because some of you, in fact, virtually everybody has been at the front line of this pandemic fight. We have frontliners, health workers who have seen this firsthand. And then we also have people who have survived COVID-19. And they're going to join us to tell us their story. I want to start off with Nana Tima, who is a COVID-19 survivor. So Nana Tima, tell us what the experience has been like. First of all, how you think you got COVID-19.
Israel, so it's difficult to tell how I got it, even though, and I've been saying this, it's easy for people to think that because my boss got it, and my boss is the Minister of Education, Dr. Prempe, and other colleagues in the office got it, it's easy to assume that I may have picked it from him or from the office or from my other colleagues. But I say that I kind of disagree. I really don't know where I picked it from. And it could be that I may have picked the virus from somewhere else. I could even have passed it on to him and my colleagues. So I could have picked it from anywhere. So I don't really know where exactly I picked it from.
Okay, so what has the experience been like? I mean, after you got COVID. At what point did you get to know that you had COVID?
So I started feeling unwell on Friday evening. Friday was 19th June. I had worked from 4 a.m. that day, so I assumed I was tired. And when I say I started feeling unwell, I was feeling tired and I was feeling hot and cold, generally feeling unwell. I didn't have a sore throat. I didn't have a high temperature. I wasn't coughing. And so with only tiredness, and when you Google the symptoms of COVID-19, the three that are supposedly the most common symptoms are tiredness, the dry cough, and then a fever. So because I didn't have a fever and a dry cough, I didn't think it was COVID. So I rested on Friday night, and on Saturday morning, I was okay. I wasn't feeling unwell anymore. So I assumed it was malaria. So on Saturday, I went about my normal, I went to do my normal rounds. And then later that day, around 12, I started feeling unwell again. It really presented like malaria. Like I was feeling hot and cold and I was feeling unwell. I would sit in the chair and I would sit on the floor and I would lie down. So I called my doctor and she said, immediately she said, well, this could be COVID. And of course, I didn't want to have COVID. So I said, no, I don't have a cough and my throat is not itching or anything. And I don't have a high temperature. So she said, okay, fine. Let's start you on a course of malaria, even though I hadn't tested for malaria. She said, let's start you on an anti-malarial course and let's see. So on Saturday evening, I got anti-malarial tablets and started taking them. And then she asked me to start vitamin C, the soluble vitamin C tablets as well. On Saturday, in fact, on Saturday, I didn't sleep much. So on Sunday morning, it was really bad. I couldn't even get myself out of bed. So I called my mother. I was then in Kumasi attending the NPP primaries. So my mom is in Kumasi as well. I called her and she came over. Fortunately for me, my mom sells in the market and she always acts as if she has the virus. And so she always has a mask on. And so she was telling me that she could have the virus and she doesn't want to pass it on to me. So she wasn't coming close to me and she had her mask on the whole time she was with me in the room. So on Sunday, I managed to get to Accra. I went to Kumasi with my driver. So I came back to Accra with my driver. It was very difficult because I was feeling unwell. I came to Accra, got home, and my doctor called and said I needed to immediately isolate because I have 3 toddlers. And I live with my husband and my cousin. So it wouldn't be good if they caught it. So I immediately locked myself in the bedroom I share with my husband, and he had to move out. On Monday, I was still not feeling well. And by noon, I got a call from the office that one of us had tested positive for COVID. And so we immediately needed to isolate. And our phone numbers had been given to the contact tracing team. And so they would call us and come and take our samples. I got the call on Tuesday morning. But then on Monday evening, my boss called and said he had been admitted at UGMC, but his test had come negative, and so they were going to do further tests. I was called on Tuesday. I needed to drive myself to the clinic at the Jubilee House because the contact tracers weren't going to come to me. I had to go and take the test. And because I didn't want to pass on the virus to my husband, I needed to drive myself. So I told the tracers I couldn't come on Tuesday. I went on Wednesday and I took the test. But by Wednesday, when I was going to take the test, I knew that I had COVID. I wasn't really waiting for the results. So I was started on a course of antibiotics. I had to continue the soluble vitamin C, soluble vitamin D, zinc tablets, some other drugs, which Dr. Petrina prescribed. I got the results back on Friday, but by then the symptoms were full blown. I had totally lost my sense of taste and smell. I couldn't smell anything and I couldn't taste anything in my mouth. And as I wrote, the symptom that was the most difficult for me was the feeling of unwellness. It was like, I didn't know what to do with myself. I was feeling very sick. And because no one could come close to me, it was quite painful because it was kind of like just me locked in my room with my TV and my books, you know. So it hasn't been a good experience. As I wrote on my page, fortunately, my colleagues in the office had also tested positive for the COVID. So it was just, we joked that we had communal COVID. And so I would wake up and call one of my colleagues and she would say, this morning I had a cough. And the other person would say, this morning I have a high temperature. And the other person would say, this morning my head is aching. So we were discussing what we were going through. And it felt good to know that I wasn't alone in all this. And I had other people who were going through the same thing. The only thing is that all of us had very different symptoms. And there were 2 or 3 people on the team who were totally asymptomatic. They didn't have any symptoms at all, even though they tested positive as well. And so generally, that is it. The most interesting thing is that when my mom found out my boss had tested positive, she called me and the way she asked, she was like, I had to say this in Chi. And I quickly had to say no because I know my mother. She's a typical market woman and she wouldn't understand. And I didn't want her to take the lead to the afterworld before me. So I had to lie to my mother that, I had tested and I was negative and so I'm fine. And so anytime she called, she would ask where the kids are. And I told her because my boss has tested positive, I have to isolate just as a precaution so the kids are not coming close to me. And I think she assumed that everybody who has tested positive is in the hospital. And so because I was home, she believed that I didn't have the virus. When Dr. Petrina called me on Thursday morning to say I was positive, she said I needed to check myself into UGMC, like into the hospital, because then I had lost my sense of taste and smell. I had a very slight cough. It wasn't a very strong cough. It's just that when I tried to talk, people were calling me on the phone a lot. So when I tried to talk or when I tried to laugh, you would hear me coughing. I read that the COVID cough is supposed to be wet, it's supposed to be dry. But I did have a productive cough, not very productive, but I did have phlegm sometimes when I coughed. And then I started throwing up. I had diarrhea. When I drink water, it would come out. When I anything I tried to eat would come back up. So I had to make do with popcorn because that was, especially tasteless and it's easier to take gradually. So at least I have something in my stomach. So when Dr. Petrina called back on Friday and I said the nausea was still persistent, I was still throwing up, she asked that I immediately check into the hospital, which was a problem for me because I'm sorry, but I hate hospitals. So I told her, okay, let's wait till Saturday morning. If I don't feel better on Saturday morning, I'll go to the hospital. Now, I must say that I don't know how the doctors do it, but this might sound cliche, but without the doctors, I don't know how I'd have gone through this. Even though they say there's no medication for it, it's nice to have the doctors well again. Maybe it's because it's me, but it was nice to have the doctors calling in every morning to check and see how I'm doing, how the symptoms are, how I'm holding up, and then adding on medications depending on what symptoms I was showing on that day. So generally, that was it. A couple of people called me when I was sick, and I said I didn't have the virus. I said I had tested negative because this is me being petty. And I also felt that they were just being nosy, because these are not people that would usually call me or would usually check on me. And so what are they looking for? Why are they suddenly asking me if I'm positive? And I was also very confused then. What pushed me to want to talk about this? There are two things that pushed me. One is the fact that the symptoms that people are asked to look out for are not the symptoms that I had. And so I'm thinking that somebody would have malaria-like symptoms, the person will take antimalarials and go to work, or the person will take antimalarials and go about their normal duties, but they could have COVID and they could be infecting other people. The other reason is that one of my colleagues tested positive, and he called each one of us in the office separately and told us that he had tested negative, which I found quite strange. It was like he was putting in special effort to tell us that he was negative, even though nobody had asked him. And we all knew he was positive. So I felt, hey, I mean, what's wrong with being positive? We should rather be grateful to be alive. The night that I found out Sir John had died, I didn't blink. I didn't sleep at all that night, because I had gone for a walk and returned at 7 p.m. So I lay down. I was reading. I picked my phone around 11 p.m. And Sir John and I are on the government CEO's platform. And so I saw they had changed the name of the platform to RIP Sir John. And I thought I was dreaming, only to open and see messages of condolence and people saying he was actually recovering and they brought him his food and then he just dropped off. And it was a very emotional moment for me, because I felt that I'm no better than Sir John. Sir John is very energetic, even though he's older and he may have had underlying health conditions. I am no better than him. And this was me lying in my bed and, taking this very calmly. So I was a bit overwhelmed that day and I just couldn't stop crying. I cried till morning. I was grateful to God that I was still here, and at least all my colleagues are still alive and they were all recovering. But then again, I was pained. I was thinking, how is the virus doing its selection? Who is it killing and who is it leaving? And so the following morning, I remember I called Oheneba Danso, the Kofanochi CEO, and he was telling me, because it's a new virus, research is still going on. They don't know who it's going to kill, and we don't know who is going to survive. And that is why we need to make sure we don't get it, because I may get it and I will survive. You may get it and you won't. And so whatever you do, try to avoid getting the virus. Do all that you can to avoid getting it.
Okay. All right, Nana Tima, I'd want to go to Dr. Chris Owu at the moment, because he is one of the frontliners. He actually works in the ICU. He coordinates the ICU as far as Ghana's national COVID responses. So, Dr. Owu, I'm sure you have encountered people like Dr. Owu, you've encountered people like Nana Tima, and some whose cases were a lot more critical. What do you make of people who say that COVID-19 is a scam?
Hey, bye-bye.
Yeah, hi, Israel. Can you hear me?
Yes, we can hear you.
All right. Okay, so thank you very much. First of all, I want to say, Nana Tima, we thank God you've recovered quite nicely, and thank you for taking up the opportunity and having the courage to share your experience with others. We've been going through this for about 4 months now, since Ghana had its first case on the 12th of March. Basically, I think we are exactly 4 months now since we had our first case. And, initially, we all thought that this was going to spare Africa and wasn't going to touch everywhere. There were sets of people who thought that this was the disease of the elites or the bourgeois. And therefore it was those who were coming back from travel who we mandatorily quarantined, who were to be worried about. But quite early, when we had seen what was happening in places like China, Germany, Spain, UK, and eventually in the Americas, we knew that this was going to come home to us. It's not everybody who has been able to go through this without any symptoms, or everybody who has been able to go through with symptoms that may be bothersome, but still do not require hospital or did not have to go into hospital like Nanatima did. There are some who spent quite significant period of time fighting for their life. And there are some who unfortunately have lost their life. And I think we're quite aware of that as a nation. I want to also take the opportunity to thank all my colleagues, both at the national level, regional, and all the way to facility levels, who are putting in their best to try to protect our country and deal with the problem. And then the patients who've gone through our hands, and also say my condolences to the families of all those who've lost loved ones. We share in their sadness and their grief. And this is a very good reason, as Nanatima said, to fight to reduce the spread. You're not going to know who is going to make it. You don't know who will require intensive care.
Right, so we're getting feedback from someone. So if you could just mute your microphones until you're speaking, and then you can unmute them, so we can hear.
All right.
Oh.
Okay. So I think in late March, just about when our number of cases was going up, and I think early April, when we lost the first few cases, at that point in time, we were basically still going through the process of setting up treatment centers. I got involved in this because two of my very good friends, colleagues, Dr. Oliver Comey and Dr. Lawrence Oforibuedu, called me up and said, look, what's going to kill people is those who will end up requiring ICU. I man an ICU in Korle Bu Teaching Hospital, and they asked me to join. And eventually I was co-opted into the national team. Now, in early April, we started losing people. It were one today, another 3-4 days, maybe another one. And there was even debate as to whether really people were dying from COVID or people were dying from other conditions and then wrongly diagnosed as COVID. But yes, the main issue at that point in time was that we hadn't even set up intensive care units to tackle COVID. And it wasn't because we didn't have intensive care units. Yes, we have difficulties in our health system. It's not as strong as we would want it to be. But our intensive care units were already overwhelmed by disease conditions because there were not a lot. And because this was an infectious disease of which a lot was not known about, we knew we could not miss the patients. We did not have the facility and the technology to make sure that people missed in the same intensive care unit hall did not contract the disease or did not spread the disease to others. So we had to start setting up ICUs, and there were a couple of patients we lost. Unfortunately, I can't mention the name now, while we were trying to set that up, and I basically was thrown a task of setting up intensive care units in a hospital that was yet to be used in their delivery suite, basically what we call a labor ward, in 3 days. With the help of my colleagues, my nursing lead, and then the hospital management that we use in that is municipal hospital, we managed to set up the first intensive care unit to take the first few patients who were very ill. Immediately we set up that ICU, the same day, we had 2 patients arriving, very ill. The next day, we had another patient. It was 4 beds. We filled it within 3 days, we lost our first patient, and that was heartbreaking because this is a patient that had been in a private facility, but not yet diagnosed, and very ill, but was suspected. By the time he got to us, he was so very ill that we had to put him on life support, and we lost him within 48 hours. We knew then that we had a fight in our hands. There have been people who've been crazily ill. Our longest patient in our ICU has spent 39 days in the intensive care unit and survived, is perfectly back home now with the family. We've had patients who spent in excess of 30 days, and those who spent even more than almost 2 weeks before coming to us. We've unfortunately also lost some people, irrespective of how aggressively we had fought for their lives. In ICUs in Ghana, or critical care, since we eventually started our setting up critical care, we basically had probably getting towards almost about 300 patients who have been in critical care now. We've lost quite a number. Majority of those we have lost are those who didn't get a chance of getting into ICU because of the capacity limitations. We've been working feverishly, just came back from Kumasi yesterday. We were in the central region last week. We're going to Western region next week, trying to assist our colleagues to expand capacity and then to also help train. But it is real. It is very real.
You mentioned Kumasi, and I'd want us to stay with Kumasi for a while, and Ashanti region to be specific, because there have been concerns that Kumasi is recording an increasing number of deaths, and people are worried. They are asking, why is it that Kumasi is recording so many deaths?
All right, so let me be quite very plain about it. As your numbers go up, the percentage of people who may be critically ill or severely ill may stay the same, but absolute numbers, because it is a percentage of the numbers that are escalating, will rocket, will go up. It happened to us in Accra, in Greater Accra region. So as the numbers keep going very high, the numbers are going to go up. Remember that we are not able to change the number of beds in our hospitals overnight, or the number of doctors, and especially doctors and nurses and other health practitioners who practice critical care overnight. These are structural changes that take some time. It means that we're stretching our health system very severely. It means we're putting huge strain on the personnel that are working. And I'll tell you, earlier on, we knew that Accra would have gone exactly the same way if we had not been able to open places like our East Municipal Hospital and able to take critically ill patient, or University of Ghana Medical Center, or Kolebu Teaching Hospital Medical ICU, or the LWAC high care area in by 37. So now you see me mention quite a number of places where we could manage the severely ill, in addition to even private places like Nyaho, Focus, IMA, and others that are coming on board, holding onto those patients and giving them at least some level of care to keep them alive until they get to us. Now, Kumasi has similar population to Accra, and their numbers are going up because a lot more people are spreading the virus. But they don't have as much facility as we have in Accra.
Okay, so it's an ICU. It's an ICU facility.
Yeah, the facility for the severe and critical, because they're the ones who are really dying. So as I speak now, they have expanded. They are doing basically more than 20 beds in Confanoche. The doctors, the nurses, they are working their hearts out, but their ICU and high care for COVID is full. So what that means is that if other facilities do not come on board, and other facilities coming on board, it's not just a structure. It is mainly personnel, trained personnel to do that. Now, so that's a problem. So it's not a peculiar situation with Kumasi. And I'm going to give you an example stepping out of our country, where our health system is nowhere as robust as it is in the United Kingdom. Emma, one of our colleagues, Emma, is in London, and the mortalities in London are way beyond what we've seen anywhere in Africa. Over 40,000 people die in the United Kingdom, but they have crazy bigger facilities, a lot more technology, a lot more human resource. But when your system is stretched there and you overwhelmed, you're going to lose people. And if you have a finite capacity that you can stretch to a limit, what it means is that you have to put every effort in making sure that you do not continue to spread the virus. If you continue to spread the virus, we'll get to that point where a lot more people are going to die.
Right. So, Dr. Uwe, in effect, what you're saying is that the more cases we have, the more severe and critical cases we're going to have on our hands, and the more deaths we're going to have.
It's as simple as that. Because when we can expand what we are doing. Yes, we can, and that is what we're doing at the moment. So over the last couple of days, we've been in Kumasi to basically bring on board one more facility that should be able to give significant support to Confanoche. We've done similar with trainings and assessment we've done in the regional by the national case management team. But our resources, human resource and then material resource, are finite. We need to be able to control that. If not, more people eventually going to die. That's the frank truth about it.
Dr. Owu, one of the questions I'd like to put to you, which I'll come to you later, has to do with couldn't we, you're talking about training, couldn't we have done the training, earlier on, so that, when we realized that, when we had less critical cases, couldn't we have prepared ourselves for the situation we have on our hands now, where we're having a lot more severe and critical cases? But I want to go to Dr. Emma in London to tell us what the situation is like at the area. No, Dr. Emma, now you have experienced the situation, or you have seen the situation firsthand in the UK. Is the UK essentially has done quite well in flattening the curve, or going around the bend. What is the situation like now, and what are some of the instances you had to encounter?
So thank you for having me on. The situation now is actually much more improved than it was going back to March, April time. In my case, I was enlisted to work on the COVID ward pretty much the whole way through the peak, throughout the months of March and April. And what we saw were very high numbers of cases, and very similar to what Dr. Wu said, in that we just didn't know exactly how this virus was going to behave. Every prediction that was made was, it was educated guesses, kind of, looking at trends from things like the flu, from things like SARS and MERS, those smaller epidemics that we've seen in years past. We really didn't know exactly what this virus was going to bring, but there were things that we did do, in that we did increase our intensive care capacity, massively. And I mean that at a local level as well as a national level. Even had new hospitals built. So we had Nightingale Hospital, which was transformed from an old event center, created 1,000 more beds, 1,000 more ITU capacity. And at the moment now, cases have come right down. Now the hospital that I personally work in, we don't have, at one point, almost all the wards were converted into COVID wards. And we cancelled all our, non-emergency things, all the non-emergency surgery and admissions. Everything became focused on COVID. And now, the cases have gone right down. We don't have a dedicated COVID ward anymore. Of course, we're testing every patient that comes in the hospital, but there just aren't as many cases anymore. So I think we're definitely seeing so much more improvement. But of course, we know that we must remain vigilant because, you know, there's not only just this second wave that everybody's talking about, but we don't want to see cases go up at all.
All right. And at this point, I would want to go to Dr. Pia Kubi, who is in Hong Kong, one of the countries that's known to have handled COVID-19 extremely well. Dr. Kubi, what is it that Hong Kong has been able to do to handle this or manage this pandemic so well?
Well, Israel, thank you very much for having me. For Hong Kong, so far, first, let me give you the figures that we have for us at yesterday. As of yesterday, we have had 1,431 confirmed cases with
1,141 confirmed cases from
1,431 confirmed cases.
From day one?
But he doesn't talk.
Yeah, from day one.
Okay.
And then we have had 1,176 recoveries with only 7 deaths.
Wow,
now,
that's impressive.
Yes, it is. To understand how Hong Kong has been, how Hong Kong has fought this virus, you should understand the historical perspective of infectious diseases in Hong Kong. You know, in March 2003, Hong Kong was hit with the severe acute respiratory syndrome, SARS, and they recorded about 1,755 cases with about 299 deaths. Okay, so now the aftermath of this epidemic, what they did was that they set up a SARS expert committee.
So when you take it, that's this, put it in water.
So the SARS expert committee, after sitting, came out with about 46 recommendations when fighting capabilities in the city. So what they did was that they did 46 recommendations, but because of time, I cannot go through all the 46 recommendations for you, but I'll give you the salient points they came out with. What they did was that they established the Center for Health Protection. That was supposed to more or less be the public health protection agency of the city. So they also improved on the quality of their medical supplies. And then they also improved on their facilities. They also trained staffs that will have more knowledge on infectious disease control. And also they also built more isolation centers and then isolation wards across 14 public hospitals. Okay, so in effect, Hong Kong was already ready for such a problem. They have had a structure in place already waiting for something like this to occur. So as soon as it happened, from when we're entering the Chinese New Year, late January, we all heard about this virus coming from Wuhan in China. And you know that Hong Kong borders China. I mean, it's just next door. So the government said, okay, now this is happening. They quickly mobilized their health professionals. And the first thing they did was that everybody should put on their mask. And I'm telling you, Israel, it's a culture here. Everyone had to put on their mask, whether you are young or old. And one good thing here is that the compliance is excellent. When they said we should all put on our mask, everybody complied. Nobody was willing to challenge why I should put on a mask or something. And if you know the Asian culture, you know, they have this flu that cuts across this area when the weather becomes a little colder. So the mask is like already a culture where people try to prevent flu when they have they have flu infection. So the mask was a must for everybody. And so far, we all comply. I never leave my place without my mask on. Okay. Now, so what they do was that they also moved quickly to seal the borders between China and Hong Kong.
Okay.
Yes, they quickly sealed the borders, even though people complained it was late. The people had to agitate a little for their government to close the border. But eventually, they closed the border. And I believe that stopped a lot of the transmission coming in from mainland into Hong Kong. Now, what they also did was that when you come in from mainland or from the beginning, you know, everybody was preventing people from coming from mainland. So when you come in from mainland, you are quickly tested. Nobody comes in without testing. So you are tested, and then If you test negative, you are sent home to self-quarantine for 14 days. Now, when you are going home, you are given a wristband that has a specific radius. So when you are home, you cannot even leave your house. I mean, when you cross that radius that the wristband prescribes, you are quickly called and the police will come after you to send you back home.
Just like that.
Exactly. So when you are home, you test negative and you are sent home. You quarantine for 14 days. After 14 days, you do the test again. If you are negative, you are allowed back into the community. Now, when you test positive, what they do is that you are quickly taken to the hospital by an ambulance. You are not allowed to mingle with the people. I mean, you can't take a taxi, you can't take the MTR, which is the public transit system. You can't take a bus, a public bus. You are taken to the hospital by an ambulance, and then you are seen, treated, and then if you get better, you are sent to the quarantine center to quarantine for 14 days. And at the quarantine center, you are tested 3 to 4 times before you are released. You are also tested again to make sure that you are negative for the virus before you go back into the community. So Hong Kong,
Dr. Apiakubi, so you're saying that Hong Kong will test you to be sure that you don't have the virus before you're released back into the community?
Of course, you can never go back into the community without testing. You have to be negative before you move back into the community.
What do you make of this WHO recommendation that when you don't necessarily need to test the person after 14 days?
Well, it's like, I'll be truthful with you. I have my own problems with the way WHO has handled this virus from the beginning, but well, it's not for me to say. But anyway, for Hong Kong, the testing is very important because of their past experience with SARS. They were very particular about this virus, and that is what has made them fight this virus up to this extent, because they were not prepared to let their guard down, to have casualties as before, as they experienced during the SARS period.
All right.
Okay, so testing is important. Now, in Hong Kong, you can test in any accident and an emergency in all the public hospitals. You can also test at the OPDs of all public hospitals. And even in private hospitals, test goes on in private hospitals. And as soon as...
That's great, Dr. Apiakubi, but it's also Hong Kong has the resources. You're talking about the technology that was used, that they're giving you a wristband and you can go beyond setting. So it's the resources that you had available. I want to go to Dr. Emma in London to find out what they also make of these recoveries or the recommendations that were given by the WHO when it comes to recoveries and discharges. Dr. Emma, how do you handle it there?
Our look differed quite a lot. We are changing and almost a recommendation because of the capacity that we had and the ways in which the UK decided to handle the pandemic. I think what Dr. Kubi said is that Hong Kong had this previous experience with SARS, but the UK hasn't actually been through a respiratory pandemic before. Yeah. So the response was very, very different. Initially, I was working on the medical wards of patients who have COVID, who either did not need intensive care support or were not eligible for intensive care support, maybe because they're already elderly or frail. So a lot just managing how we could on the ward, and some survived and some didn't. With regards to those who survived, I know initially we were sending them back to nursing homes once they were 8 days after a positive swab, as long as, of course, they were clinically well enough to go. Later, we realized that 8 days was too short, and then that extended to 14 days. So it's quite harrowing to think about those that maybe we sent back to nursing homes too early. Did that mean that they went then nursing homes and spread the virus to all those around them? It's very harrowing to think of this, especially because later on in the pandemic, we then saw massive spikes of the virus in nursing homes, and we worried if we had made a similar mistake, because Italy had also done something similar, and we know that their numbers were through the roof. Later on, this changed, so we increased it to 14 days. Also, initially, we weren't re-swabbing patients because for a number of reasons. Firstly, there were some people who we initially tested for COVID with a swab, who had a negative swab, but quite obviously had COVID because they were behaving like they had COVID. The imaging of their chest showed that they had COVID. They just looked like COVID. So and for those who had a negative swab, it just felt that we can't put all our bets on this swab. It's obvious that this person has COVID, regardless of 1, 2, or 3 negative swabs. So we felt there was no point in re-swabbing people before sending them home. The second issue as well is that taking a week to get back the results from a swab. So we would swab people, we wouldn't get the results back from a week, and then even when we got the results back, we weren't sure if, how much to rely on it. So we were going a lot by clinical basis, clinical examination, X-rays, CT scans, things like that can tell us how this person is behaving regardless of the test result. Right. So we weren't testing people to say, oh, your swab is now negative, that means you're safe, because it just wasn't true. And we also didn't want to be a case where we told people, you now have a negative swab, that means go home and be happy with your family, which would be just as dangerous. So it was, let's not swab you, we think you're better, but you need to go home and continue to isolate, because for all we know, you could still be transmitting the virus, even though you're feeling much better.
All right.
Strategy was very different. At the moment, we're relying much more heavily on swabs because the swabs are being turned around much more quickly. If I swab someone today, I'll get the results tomorrow.
All right.
Relying a lot more heavily. And secondly, there are so few cases now really in the local community. And I'm speaking particularly for London only. I know parts in the north of England have very high cases still. The community transmission is so low that we think, it's worth putting a bit more emphasis on the swab and ensuring that we're getting negative swabs before we send people home. So it's all varied quite differently, and it's required us to evaluate our local policies very often.
All right. Dr. Owu has his hand raised, so I'd want to go to him. Dr. Owu, you want to make an intervention?
Yeah, so thank you, Israel. I just wanted to contribute to that particular discussion because it's important to put things in context, so that, and every country, every continent has had absolutely different context with respect to this pandemic. The same way that the pandemic did not arrive in every continent at the same time, lessons learned had been learned at different points in time, and people have generated their own data while they are having the pandemic in their own country. So it's always so very easy to say what could have been done better from hindsight, but nobody had hindsight. It started off in Asia, so of course the Asian countries had a better awareness what was happening in China, and whether this was going. I mean, when it was in China, nobody expected it to be a pandemic. If anybody in Africa or in Europe says today that somewhere January, February,
are you okay?
That they knew that it was going to be a pandemic, then I'm not sure whether that person is being truthful. Now, other countries have also had different experiences, as Emma mentioned. Africa, a lot of the experience in Africa has been with more of hemorrhagic infectious diseases like Ebola and dengue and others, not as much with respiratory epidemics or pandemics. Now, it basically meant that nobody had run a budget in the beginning, at the end of last year, preparing for an epidemic in their country. Neither did Ghana have that. The health system, basically, we all knew was already problematic, and it wasn't going to change overnight. It basically means you had to repurpose things. By repurposing meant that you also are aware that your caseload or your disease load from other conditions did not just suddenly disappear. It has meant that we probably have also had excess deaths from other conditions that were putting burden on our health system. So at the time this arrived in Europe and Africa, and of course, Northern America, we all knew that at that point in time, it was even difficult to get personal protective devices. Yeah. China was at the height of it, and most of these items were coming from Asia. We started off with inability to even get the face masks, both the N95s, FFPs, and all that, because of course China had an epidemic and they were not exporting to any country, absolutely not to Africa at that point in time. It basically meant that you had to draw up your plan based on your country experience. Yeah. By the end of April, May, we were quite aware how long it was taking us for our patients to recover from COVID. And we knew that it was between 10 to 14 days. WHO has had its challenges, but I wouldn't bastardize WHO. There's absolutely no country in this world which would tell me that they have handled this perfectly. Every country has had their difficulties. US has had difficulty, UK has had difficulty. They all have strong health systems. WHO had to bring those information from different places to try to make a decision in a crisis environment. I think it is wrong to bastardize such an associate organization. But what we should be aware is that it is these information that people are getting in their national context or in their regional context that fits in. Ghana, we did not adopt that from the very beginning, but when we knew we could document what how long it was taking for people to recover, we knew that over 95 to 98% of our patients were seroconverting or changing to negative between 10 to 14 days. Then we could say that after your symptoms has resolved, or if you were asymptomatic, 14 days after, and that's what public health really is about, to learn from what you're experiencing and impute that to how you manage, especially in a crisis. And I think UK had similar, US is having similar. Every country is going to have an experience. They are going to use the lessons they learned from that experience to guide their guidelines to be able to respond. Those who had previous experience with respiratory illnesses had better experience and better preparedness. They probably had already built such systems previously, and they could activate that on short notice. We didn't have some of those to activate. We had to build them de novo. You can't train an ICU expert in 2 to 3 months. It takes 3 years to train fellowship in critical care. It takes 2 years to train nursing critical care fellowship. Yes, you can improve people's knowledge to manage, but you can say that these are things that I was expecting would happen in 2020, and therefore my system was ready for that. So that's the context I want us to understand. So
thank you very much.
Yeah.
All right, thank you very much, Dr. Owu. Now, this conversation really, I intended to have a conversation where we all are going to come up with ideas as to how we can stay protected, stay safe, so that we don't get COVID-19. Because as we have heard from the doctors and the survivor, Nana Tima, it can get really bad when you get the virus. So I'm going to make it open to everybody. I want you to come up with suggestions, especially those of us in Ghana, how we're going about staying protected or staying safe, and how we can make it better. So I want to start with myself. I keep my nose mask on virtually all the time. Immediately have to leave the house, I make sure that I have my nose mask. Now, if I get out of the car, I'm putting on the nose mask before getting out of the car. After doing whatever I have to do, I come back into the car. I sanitize my hands first before I actually take off my nose mask. And I have an N95, and I just put it on the dashboard, because my understanding is that all you need is for the sun to hit at it. And so I leave it on the dashboard. Whilst I'm driving, the sun is, the sun is hitting at it. And when I get home, it's packed out and the sun is still hitting at it. This is what I'm doing. I may be doing something wrong. If I am, I'm expecting that you, the doctors and the frontline health workers, can advise. And that advice goes to everybody else who's also watching and joining the stream. So I want to start with Dr. Emadai. You haven't spoken yet. So Dr. Emadai works with Dr. So, Dr. Adai, your boss is speaking. We would also want to hear from you.
Okay. Hello, Israel, and thanks for having me on board. So I've listened to all that has been said. I think essentially most of our sentiments are the same about how the since it hit this country up to this point. When it comes to precautions or things that we can do to try to mitigate the spread, I would first want to emphasize the hand washing. That's where I want to start from. I want to emphasize hand washing. I want to emphasize thorough and frequent hand washing. I think we need to get to a point where the hand washing becomes part and parcel of us. As in, even, I think we have to get to a point where hand washing comes to us as naturally as holding or talking about phones. That we, and I think one of the ways to inculcate that habit start from our home. You know, make sure on a family level. We all come from smaller units, family units. So if we start on the family level, and every family or every unit makes it a point to ensure that every member, adults, children, everybody is washing their hands thoroughly. You know, because in Africa, in Ghana, previously hand washing culture. There are people who wouldn't wash their hands before they eat. They would wash their hands after. A whole lot of myths go around with hand washing. So COVID and all this emphasis on hand washing, it's kind of difficult for people to do or to remember to do frequently now. But it needs to become second nature. Emphasize it also in our schools, add it to the curriculum at the early age. Because I know this hand washing is taught to children in school, so that by the time they grow up, it's already part and parcel of them. Because we've all learned that if we wash our hands frequently, it increases the chances of picking up the virus and then transmitting it. So the first thing I will say is we should all make the part and parcel of us and teach people. Next thing I want to stress is the social distance or the physical distance. That's also very difficult because in Ghana, it's not our culture. We are people who like to interact, to hug, to shake hands. So this is actually very difficult for us to do. And as much as environment is good, I think a lot of it people decide or naturally tend towards adopting the constantly having the better. So it can become culture, just like we have this culture of greeting. If we can learn to keep that distance, I think it will go a very long way to help us all. So that one, it's about us being each other's keeper, because that's what it's not easy for children, for adults. We all know it's not easy at all.
All right.
And so we just have to be keeper.
Now let me go to Dr.
Those are my first two suggestions.
All right, I'll go to Dr. Oliver Comey. I was in Accra Central at some point in time. I had to go and buy something at Accra Central. And I was looking at the crowd at Mokola and the people mingling. It's very difficult in such a situation to say you're social distancing. How do you go about it? And if you happen to have gone through Mokola, what do you do when you get back home? You can wash your hands, but the virus could have, running onto your clothes or something. How do you? And of course, there were people too who were not wearing the nose mask, and there were people too who had dropped the nose mask and it was under their chin. Dr. Oliver Comey, what do you have to tell such people, and what do we do when we find ourselves in such environments and get back home?
Good afternoon once again to everybody.
Good afternoon, Doc. And if you could, turn on your video so we could see you.
Israel, I hope you can hear me.
We can hear you, but we're having some difficulty. I'm not sure if it's your internet connection. Okay, it's gotten bad now. Now, any takers on the question I'm asking? How else we protect ourselves? Okay, we can hear you now. Yeah.
You can hear me.
Yeah.
Okay, like you said, we all need to protect ourselves. The recommendation is that anytime you're stepping out of your house into a place where you know physical distance could be a problem, you need to wear your mask. We acknowledge that you can't go into the marketplace and maintain physical distancing. So the first thing is protect your nose, protect your mouth. As soon as you get home, first thing you do is if you have a chlorine bath at home, you can step in that chlorine bath or a mat just soaked with bleach. You can step on that one just to clean your feet. And then you can head straight into your bathroom and take a good bath, a good shower. Wash your hands very well. In that case, if you are thinking the virus is stuck onto your clothes or the virus is stuck onto your skin, you would have washed that one off. If you had your mask in place, you would have protected your nose, you would have protected your mouth. Those are the things I think we should all do. We cannot run away from mingling with other people. But if you have to go anywhere where you are not too sure of the people around you, first protect yourself. Then you can say that others should also protect themselves. I believe we should all take personal responsibility first. Then we can encourage our brothers also and our sisters to protect themselves.
All right, thank you very much, Dr. Oliver Comey. Now, we have some comments coming on YouTube. I'd just like to read them, go through them quickly. Isaac Dati says, please, can anyone that has been healed from COVID-19 be infected again? The last time I checked on that, they couldn't tell me. Richard Dodu says, please, want to find out that if you have been infected by the COVID and you have been recovered, is it possible to get it again for the second time? The same question. Richard Quiz says, hi, Dr. Owu, okay, not quite clear. While you await, what do you do while you wait your results, especially when you're a health worker and family man? So I'd want to go to you, Dr. Owu. Take the first three questions.
All right, thank you, Israel. Okay, so the first question was basically whether somebody who's been infected can be reinfected if it's recovered from COVID-19. Yes. We do not have any evidence at the moment to suggest or support that. We've actually on our own also, and I think a lot of countries has been trying to look at the data to see whether that is possible, and therefore to decide what to go about it. Now, again, we are just basically 6 months into this pandemic for the whole world. There's a lot we still do not know. I knew there were papers that came out from Spain just recently talking about whether they are finding antibodies, which are basically the things that fight your infection when you get an infection, and sometimes they linger on for years if you have prolonged immunity. And they are suggesting that after 3 months, they are finding antibody just in about 5 to 10% of the people that they have looked at. It's a small data. What it means is basically, would there be another wave of COVID-19 if people are getting it at different times and therefore can be reinfected? We don't know. We are trying to be careful, cautious. What we are saying is that even if you've had COVID before and recovered, that you should still continue to wear your mask when you go out. A lot of people have that notion that if I have had it and recovered, I cannot have it again.